Good morning, everyone. Myself, Dr. Pradeep Kumar Davla, and I'm working as a professor in Department of Biochemistry, GB Pant Institute of Postgraduate Medical Education and Research, which is situated in Delhi, India. And I'm very thankful to the organizers for inviting me as a part of this esteemed conference and inviting me to talk about uh, the artificial intelligence and its role into the laboratory medicine. So today, the title of my talk is Intelligence-Based Lab Medicine, New Chances or Challenges. So I once again thanks to the organizers for inviting me to be part of this esteemed conference. Thank you very much. So we are going to discuss the current talk under the different headings, likewise the clinical testing, where the lab stands, what do you mean by the artificial intelligence, and how the Indian healthcare is working for the digitization, and what the National Digital Health Mission India is working to make it more uh, specialized for the healthcare needs of the Indian citizens. Let's go ahead. So, when we talk about the clinical test, we uh, can't comment specifically that it is simple or complex. So, because there are so many factors which are working in this particular era that happens to play a quite important role into decision making, and we cannot rule out that the patient who is coming to our clinic in today's era is quite well versed about their own plans. So the patient of today plays a much larger role in decision making regarding their treatment than previously, and they have a more knowledge about their own diseases, and that makes a greater demands on to the health services. So today's clinical lab is one of the hospital largest department and provides about the 2/3 of all the objective information onto the patient's health status. Thus, the lab produces the vital information which is effective for the healthcare delivery. Thus, in that case, the lab becomes the most important source of the diagnostic information into the medicine or to the healthcare industry. As you can see from my slide in front, that in current era also, now we are moving from the one size fit all medicine to the stratified medicine. Then further we are progressing and combining together the various diagnostic investigations and the clinical acumen to provide the precision medicine. That means we are trying to provide the therapy which is specific for that particular patient, for that specific disease. Now, where the lab stands, the paradigm shift and innovations into the lab medicine are helping to provide the diagnostic and therapeutic care to the millions of the people into a timely and cost-effective, sustainable manner. And the clinical labs should be operated surely with a good balance of the medical practice, education, research, and the management. Thus, we can surely state that the lab personnel are instrumental in the selection of devices and to the various different processes which are quite um, important for the delivery of the healthcare services, though not limited just to the testing process only, but we extend our services to the education and training, maintain the quality assurance, verification of the proficiency operators, the compliance of the regulatory requirements, reimbursement of the testing protocols, likewise which tests to be included for which particular testing protocol that can be reimbursed. Thus, we can surely say that the laboratory medicine must work to redefine its position, adopting the new role and the responsibilities beyond its classical role as a provider. thus to work for the opportunities to provide the highest impact clinical services that result into the better clinical care and the outcome. When we talk about the global lab informatics, the global lab informatics market is established um, to reach approximately the US dollar 5.6 billion, which is projected by 2026 from US dollar 3.4 billion. That was the outcome in 2021 year at the compounding annual growth rate of the 10.8% during that particular forecast period. So the growth in this market is, if you see, it's mainly driven by the increasing need for the laboratory automation, development of the integrated lab informatics solutions, increasing need to comply with regulatory standards, and a growing demand in biobanks and biorepositories. So it means that this is more requirement of the informatics is uh, developing, and we are adopting new and more technology to fulfill those demands. And as I said, that there can be many market dynamics which are working behind this increasing demand needs. However, we cannot deny that the COVID-19 era has taught us a lot, and we have started using the technology more faster and more better. So, when we talk about again the evolving technologies, so the new clinical markers must provide a more information in readily and available manner and in affordable fashion also. That the that current standard practice must meet the higher standards of the precision and accuracy, and to deliver the services into the cost effective manner for the better detection of the risk and prevention of the CVD. So, if you see in this current figure, that for example, I've taken example of the cardiac biomarker. So, if you see prominently, so there are the 6 major axes from which those new biomarkers can be developed. Likewise, the inflammation, the oxidative stress, neurohormonal activation, renal dysfunction, cardiomyocyte injury, and the matrix remodeling. So we can say that there are major unmet need in the provision of the valid surrogate endpoints or the therapeutic targets. And if we go ahead, risk monitoring in the chronic setting, for example, as in case of heart failure, the B-type cardiac natriuretic peptides and the cardiac troponins efficacy in application treatment. So much lot work is still needed to do. And again, now the new technologies as being developing is like omics, which are extensive for the screening of the markers. Now, what is artificial intelligence? As we all know that it's not about developing the robots. It's not about developing something which will do our work, but it is something which is the technology which is going to help our work to make it more better for the patient healthcare delivery and more, of course, more with a more of precision and accuracy. So artificial intelligence itself, it describes a range of techniques that allow the computers to perform the tasks typically thought to require the human reasoning and the problem-solving skills, using either predetermined rules and search algorithms or pattern recognizing machine learning models, and then make decisions which are based onto that analysis. That's processing large amount of data and recognizing patterns into that data in multi-layer network of interconnected units like neurons, that is called the Internet of Things, that is the IoT. So over the past several decades, there's a great potential for AI, that is artificial intelligence, has been seen to improve the healthcare, and the remarkable promise of AI is particularly centered onto the machine learning, including the deep learning, as well as into the medicine. I mean, if we see that AI is not at all new to to the mankind, but it is all much available in our home into the various forms like Google Maps, like Android phones, the various apps, technology, mobile health engineering. And again, in case of COVID era, if we see the several apps which were developed for the education, for the traceability of patients, for marking the different areas. So in medicine, this is the beginning to have the impact particularly at the three levels, if you see. The first for the clinicians and lab professionals, which is predominantly by the rapid, accurate imaging interpretation and the diagnosis. For the health system, it is by improving the workflow and the potential for reducing the medical errors. And for the patients, it is by enabling them to process their own data to promote health. So, AI in clinical health, into the healthcare and with the evolving technology is supporting the different areas. As you can see into the particular diagram that the figure that the role of artificial intelligence into the particularly medicine is quite widely varied, and combining all the branches, all the hands together can give you an output which can help you into the various aspects of the healthcare, likewise the clinical decision support, where the AI can play a key role into the clinical decision support system and delivery of data to providers to aid into the diagnosing and the treatment planning to reduce the cost. Of course, it is a great opportunity to use the AI in healthcare for the cost savings. The patient data will become easier to find the meaning into the massive mountains of the patient data that we call as the data mining. So, meanwhile, we have, our Committee of Mobile Health Engineering, which is a branch of the International Federation of Clinical Chemistry, and the Emerging Technology Division has worked a lot through the last several years to develop the significant change of using the AI into the healthcare. So, we have also developed the papers, like as you can see that we have developed the opinion paper during the COVID time, which emphasize that how these AI techniques have proven to be powerful tools in fighting against the COVID-19 pandemic. Another example by another researcher, that is Martin et al., it shows the machine learning algorithm which incorporate the age, sex, time selection with the paired high sensitivity cardiac troponin I concentrations was trained onto the thousands of the patients, and then further that has been developed to test onto the algorithms of the 3-hour pathway and 99th percentile at any time point, and allowed an individual and objective assessment of the likelihood of the acute MI. The next slide, we have also the team ICC MHBLM with Team India were able to gain and design patent with Australian government titled Developing Early Risk Estimation Machine Learning Model in Early Onset CAD Patients for the Prediction and Outcomes. Further, we also strengthen the importance of AI in healthcare by publishing the white paper titled The Collaborative AI and Lab Medicine Efforts for Precision Cardiovascular Medicine. Well, when we talk about the value impact of laboratory testing on the healthcare interface, so fundamentally, if we say the clinical lab test should be adding value to the healthcare by being clinically valid, that they provide the highly accurate diagnostic prognostic information for the decision making. Clinically, the test should be clinically effective, that they contribute to improve the patient-centered outcomes, and they should be cost effective, that they contribute to the reduced healthcare cost. So, in case of Indian healthcare, if you say the India is ranked amongst the 3 largest healthcare markets into the world and has a massive count of 1,96,312 hospitals which was the previous data, it must have increased by now. And with a population of more than 1.3 billion, and the availability and the need for healthcare services can be bridged by transforming the paradigm of digital healthcare in India. Well, when anything opportunity comes, it comes with a few challenges also. So in Indian healthcare, the challenges particularly are the patient-centric care, where they seek to take control of the health by using the technical gadgets or digital devices. It can be the value healthcare replacing the volume healthcare, means the patient resort to a digital technology and use wearable and IoT connected devices for the self-monitoring. And thirdly, the integration of big data and cloud-based analytics, that is the training of doctors, maintaining the records and installing the health information system. So what we call as the ABDM. The ABDM is the Ayushman Bharat Digital Mission. This was earlier known as the National Digital Health Mission, that is the NDHM. And this National Digital Health Mission was launched in 15 August 2020 by Honorable Prime Minister, Mr. Narendra Modi ji. And the Ayushman Bharat Digital Mission aims to develop the backbone necessary to support the integrated digital health infrastructure of the country. And it is being governed by the NHA, that is the National Health Authority, which is the apex body, and has entrusted with the role of designing the strategy, building technological infrastructure, and the implementation of the Ayushman Bharat Digital Mission to develop the national digital health ecosystem. So this is to strengthen the accessibility and equity of health services, including continuum of the care with the citizen as the owner of the data, that is a citizen-centric approach. And so it is to be considered as a major step towards achieving a citizen-centric healthcare system by generating the unique health ID, digitized health record, as well as the history of the doctors and the health facilities. A big leap toward achieving something quite enormous into such a large population. So the digital health records have a potential a lot into the Indian healthcare market by virtue of the different opportunities. Likewise, the medical tourism, with its cost-effective treatment techniques and the large pool of the proficient physicians. So India is the favored medical destination for the patients from the several countries. And quality without compromise, that means the Indian healthcare is much cheaper than the Western countries while providing the same quality healthcare. The mutual collaboration agreements have been signed between the India and the other nations for the medical cooperation and the collaboration. So if you see the Indian healthcare health tech market poised to become the 25 billion opportunity by year 2025, which can increase more as it seems with the current trending, and the impact of COVID-19 will catalyze the adoption of health tech products and services in India greatly. So, if you go ahead, the need for digital health records always comes with the data protection and the various points where we need to consider. Likewise, the data protection and the role of NHA, the first digital health records by notifying the standards and recommendations under the existing legal framework like the Clinical Establishment Act was being considered in 2010. Consequently, the National Digital Health Blueprint was released for the public consultation in October 2019, and in 2021, the Joint Parliamentary Committee has submitted its long-awaited report as a Personal Data Protection Bill. The Personal Data Protection Bill will help to protect the privacy rights of the individuals and promote the fair, transparent use of data for the innovations and growth unlocking the digital economy. So to conclude, the cooperation and close communication is the key, and there's a need for the growing cooperation to provide the guidance onto test selection for the interpretation of the analytical results. And in addition to refining and building upon studies to enhance diagnosis and prognosis with upcoming AI focus into the various techniques and into the various fields like cardiology, that should include the development of AI-driven algorithms to aid the clinical decision making on test appropriateness and test selection and scheduling. So, uh, this is, I conclude my talk for today, and I say thanks to the organizers again for inviting me as a part of this talk, and thank you very much for your patience with me. This is Dr. Pradeep Kumar Atla, a professor from the Department of Biochemistry, JB Pant Postgraduate Institute, Delhi, India.
As I said before, I'm Chiara Campone. I'm from the University of Genoa in Italy, and the title of my presentation will be Glasses to See Headaches Well, a case of pilocytic astrocytoma. Let me share my screen. Okay. All right, so as I said before, headache, don't you think about the ophthalmologist? The title maybe a little bit, as I said, unique, may raise some questions. As I said before, this is a case of a pilocytic astrocytoma. And so let's talk about Isabel, a 3-year-old girl who arrives at Gaslini Institute's emergency department in April 2021 for worsening of a cephalologic picture which had arisen in the previous months and for which corrective lenses had been prescribed in relation to worsening of a known astigmatism that this time was associated with vomiting on walking, ataxia, and motor impasses from the morning itself. From the anamnestical point of view, both familial and physiological perinatal didn't show any relevant factors. On the objective, the clinical examination, the little girl presenting in pain with grimacing at the transition to clinostatism. She presented at the examination, as I said, she didn't present anything on her body except for a soil cafe au lait spot at the left pectoral side. On the other end, on neurological physical examination, we found that she presented dysmetria on coordination tests, a positive Romberg, and an unstable broad based gait, and obvious lurching and tandem walking. Therefore, after the evaluation, since we had a suspicion, of course, of a process in her, in a neurological process, a strong suspicion of intracranial hypertension. Both neurological and ophthalmological evaluation was performed. urgently, and they both gave an indication for a urgent imaging study that, as we see in the picture, was represented by encephalic MRI. This is a picture of what we saw at MRI before the treatment. And this investigation demonstrated the presence of an intrinsic cerebellar productive process. It decompensated triventricular hydrocephalus and prominence of the optic papillae. So urgent external ventricular shunt placement surgery was performed. So once the patient was hemodynamically stabilized, the surgery performed exeresis in a apparently complete way, an exeresis of the lesion that, as we will see after, was complete at post-surgical follow-up. The final diagnosis of the process that was exported was a non-BRAF V600E mutated pilocytic cerebellar astrocytoma. Nowadays, this child is in neuroradiological follow-up at our center. And last time I saw her was a year ago when at MRI control, she presented a minimal residual disease, and we gave her the indication to remove in the surgical way, to remove the mass, the residual mass, but in this time in elective way. However, before the medical history showed that Isabel the girl started to manifest headache as early as 3 months earlier in February, when she was taken to the ophthalmologist's office due to a finding of astigmatism, and correct lenses were prescribed, but with no improvement in the headache picture. So pilocytic astrocytoma is the most frequent glial tumor, and it accounts for 17.6% of all primary childhood brain tumors. It is a tumor of low biological activity with low incidence of metastasis or malignant evaluation, and having a 10-year overall survival that is over 96%. The mean annual incidence is 0.91 per 100,000 population, predominantly affecting the first 2 decades of life, with a mean age of onset of 7 years. It can affect any encephalic site, and among these, the posterior cranial fossa predominates, ranking secondly only to medulloblastoma. Clinical presentation is heterogeneous, and depending on site, age of onset, tumor biology, and possible presence of intracranial hypertension, and typical of the expansive FCP lesions. Surgical radicality, that is considered the gold standard of treatment, determines the subsequent treatment course and follow-up. Fundamental is the differential diagnosis in all cases of in all cases of headache with red flags, anamnestic or clinical risk factors that allow the indication of patients worthy of further investigation. Among the main ones are age inferior, lower than 5 years, acute or worsening onset of headache, especially if nocturnal or waking child, vomiting on walking or jet vomiting, visual disturbance, motor and balance disorders. So, could we done better or sooner? We have looked for literature, and this is what we have found: that refractive defects and headache are extremely common symptoms in the general population. Among 10 to 20% of this is astigmatism. But despite the common beliefs of cause and effect relationship between the two, today there is no evidence that such deficits can cause headache and that HARE is actually a rare phenomenon. It's actually a rare phenomenon. HARE is a specific form of headache that is characterized. Here we have the diagnostic criteria. So it is characterized by uncorrected refractive errors, mild headaches in the frontal region and in the eyes, and pain absent on awakening and aggravated by prolonged visual tasks. Nevertheless, the ophthalmologist remains the third specialist consulted in cases of recent onset headache. Finally, that more than 70% of headaches with refractive defects improve after adequate correction, and 40% report complete resolution. So let me add something. When this case report was published on an Italian scientific journal, I received a comment from a young colleague who taught me the importance of the ocular B-scan ultrasonography in the assessment of the optic nerve sheath diameter, ONCD. I found it extremely useful and important to be taken into account as a necessary diagnostic standard to enable headache screening, especially in view of the non-invasiveness of the examination and the greater accuracy than fundus assessment alone. Therefore, I am sure to say that the ophthalmology evaluation remains a cornerstone in the framing of the pediatric patient with headache. So finally, what our clinical case teaches us, that at preschool age, in the presence of headache with red flags, it is indicated to proceed as soon as possible with specialized and neuroradiological investigation, especially brain MRI, that is considered the diagnostic gold standard in hemodynamically stable patients. Although this approach results in a high demand for imaging in the face of low incidence of intracranial pathology, it should be considered even when, in the absence of red flags, the headache does not tend to improve, in order to avoid a possible diagnostic delay. So thank you for your attention. Here's some of the bibliography that I used for this case report.
Hello, I'm Vera Lucianoki Cardim, plastic and craniofacial surgeon from Brazil, and I would like to thank the Congress Organizing Committee for the honorary invitation. The treatment of congenital malformations for more than 44 years generated experiences that could be commented in this article from the Archives of Pediatric Neurosurgery, which I would like to share on this opportunity. We can didactically separate congenital malformations into dysplasias and dysostoses. In dysplasias, there is a change in the migration and fusion of embryonic process. And in dysostoses, the mechanism that is altered is the maturation of bone and sutural tissues. Orbital hyperteleorism can be present in both types of malformations, but with different characteristics. In dysostosis, it manifests as a secondary defect to the early maturation of the cranial sutures. Endocranial hypertension, generated by the premature fusion of one or more cranial sutures, causes the frontoesphenoid-ethmoidal sutural complex spared from stenosis to grow in compensation, expanding the floor of the anterior cranial fossa and thus causing separation between the orbits. In dysostosis, the separation is generally relatively discrete and accepts correction with medial mobilization of only the medial walls of the orbits, as proposed by Converse in 1959. In this case, we perform a monoblock frontofacial advancement by intracranial approach. In adult patients with reproduction of cranial deformity after back table surgery, we need to make the calvarial bone malleable, and we do it with these helicoid osteotomies with minimal dural detachment. After cranial decompression and modeling, we focus on the medialization of the orbits, done again by approximating the medial walls. Here, we see the regularization of the frontal bone with the refinement of bone powder graft on the surface of the forehead, and the decrease in the interdacranial distance. Moving now to the analysis of hyperteleorbitism in dysplasias, we need to go back to the first 4 weeks of intrauterine life, when the optical processes are still beginning their formation at 180 degrees, and the ectoderm differentiates into neuroectoderm. The neuroectoderm produces the hedgehog family, which are cytokines that manage the migration and fusion of embryonic process. The PAX6 factor of the hedgehog family induces the optical fields to approximate. Sonic hedgehog suppressing SHH suppresses PAX6 to stop the medial migration of optical fields and keep the eyes apart. When we therefore have a predominance of PAX6 factor suppressing SHH, we will have hypoteleorbitism with the absence of the central tissues of the face and skull. And if SHH predominates, we will have hyperteleorbitism due to the suppression of PAX6. Hyperplasias of the central line of the face and skull, which correspond to the numbers 014, 113, and 212 of Paul Tessier's classification, characterize hyperteleorbitism. It can manifest itself in various degrees which were classified by TCE from 1 to 4, the latter being the most serious, with an interdacryle distance of more than 4 centimeters. When the floor of the anterior cranial fossa is preserved, generally the nose and the center of the face are short, with palatal collapses and anterior open bite, and hyperteleorbitism is considered frontonasal dysplasia. When there is protrusion of brain contents through the anterior base of the skull, the face and nose appear elongated. We can then divide hyperteleorbitism in frontonasal dysplasia without and with meningoencephalocele. Grades 3 and 4 hyperteleorbitism, even without meningoencephalocele, usually require an intracranial approach. And even today, after half a century, we find surgeons who preferably use this technique. It was called TCE box or glasses and medially mobilizes the 4 anterior margins of the orbital walls, neglecting the bone of the nasal dorsum and reconstructing it with a bone graft. The earlier is carried out, the greater the loss of results during growth, making intervention necessary during adolescence. The same is observed in this case, in which we need to bring the orbits closer together during adolescence, in addition to the advancement of the middle third of the face and the rescue of tooth germs trapped in the zygoma and maxilla by mobilizing the orbital floor at an age when there is still no aerated maxillary sinuses. Even at the time when the only known treatment option for hyperteleorbitism was the tissue box, we proposed to preserve the bone of the nasal dorsum instead of resetting it and replacing it with a graft, obtaining a three-dimensional reference for mobilizing the orbits. But it was van der Meulen who really changed the course of hyperteleorbital treatment, proposing a craniofacial disjunction with superior medial rotation of the hemifaces. This child underwent surgery at 1 year of age, and it is clear that growth did not cause a recurrence of the orbital separation, because the mobilization of the entire morphofunctional unit of the face allowed the rotation of the maxillary orbicets, transforming the mastigatory forces into allies for the medialization of the orbits. At 28 years of age, her interorbital distance remains maintained. And whenever we do not have a major lowering of the anterior fossa floor, we can perform the bipartition extracranially. The orbital hoofs remain intact and the facial halves rotate. And if we keep the central axis of the nose intact, we will obtain a better static effect with less tissue damage. The excess interorbital weight is removed between the central axis and the medial walls, and the craniofacial disjunction is performed via palatal approach, where a surgical osteotomy is performed, which will allow the rotation of the hemifaces. Ziplasty on the nasal dorsum serves to lengthen the nose and also avoids the coronal flap elevation. Another case with the same principles, and for grade 1 and 2 cases, an extended rhinoplasty with an extracranial approach. The plastophire's approach and lengthening of the nose, and does not leave an unsightly scar, as you can see in this case and in this other. And when there is meningoencephalocele, in addition to respecting the floors of the orbits and dental germs, the biggest concern will be the reconstruction of the anterior cranial fossa floor with the reduction of herniated brain tissue. But this reduction will be into an inextensible cavity, certainly producing an increase in intracranial pressure. In this case, for example, the herniated brain tissue was reduced, the orbits were medialized with an inverted U, and the child developed endocranial hypertension and skull deformation, resulting in scaphocephaly. As he was still under 2 years of age, we performed osteotomies parallel to the compromised sagittal suture, and we apply springs to distend the dural sac, and remodeled the entire skull, including areas of secondary defect. The symptoms of hypertension have disappeared, craniofacial growth has been occurring normally, and there are no signs of scaphocephaly. In this case, in which the correction of hyperteleorbitism with inverted U was also made, scaphocephaly only appeared at the age of 4, with a major clinical manifestation of endocranial hypertension. With the bone mature and inextensible, remodeling of the secondary deformity by the action of springs is not expected. The helical osteotomies of Nautilus in the mature skulls allow the remodeling of secondary defects, and despite deformities of the cerebral mantle with weight disorders, the patient has been developing quite well. No recurrence of the scaphocephalic pattern. I greatly appreciate your attention. Thank you.
Thank you for those who are listening. I am going to speak about how sentence recall or sentence imitation can be used as a screening measure to identify children with developmental language disorder. So next slide, please. Next slide, please. Thank you. Okay, so I'll just talk a little bit about the background to the study. And then I will, no, we need to go. It's okay, you can stay there. Then I will talk about the aim and objectives of the study, the methodology. I'll share some of the results and the conclusion. And of course, you are interested in clinical implications of the study. Okay, so basically sentence imitation, which is also referred to as sentence recall, is associated with working memory and the language proficiency of children. So this is very often sentence recall, a short test, very language specific, which can be easily administered in a short time, whereas normally assessment of speech and language skills in children may take 1 or 2 sessions of at least 45 minutes each. So obviously time means money. Time is very precious for everyone, including clinicians. So obviously we are eagerly trying to find ways and means of how we can be effective in as minimal time as possible. Now, what do I mean by working memory? Basically, working memory has been defined as the ability to recall and manipulate information, and not just linguistic information. Okay, and as we develop, working memory skills are utilized and progress. But it has been clearly indicated that children with language impairment, nowadays we call them children with developmental language disorder, as they grow older, it becomes a disorder, actually tend to have some difficulties both with language proficiency and working memory. And in fact, sorry about this, it's my reminder. Basically, it has actually been reported that this is the situation. Compared to age-matched control, children with language impairment tend to make more errors on sentence imitation. So sentence imitation, and in fact, has been developed as a screening tool in many languages, including our native language, which is Maltese. And in our case, also, it has shown high sensitivity and specificity, as well as accuracy levels in identifying language impairment. So obviously, sentence imitation is nowadays used as a robust clinical marker to identify children with developmental language disorder. Next slide, please. Okay, however, there is also another useful tool which speech-language pathologists tend to use and psychologists, which is non-word repetition task. And this is also has been reported to be a clinical marker for developmental language disorder. However, it has been indicated that apparently sentence recall is more robust statistically than non-word repetition. So more and more researchers and clinicians are interested in using sentence imitation or constructing it if they don't have it in their specific language. Next slide, please. Thank you. But as the world is progressing, there's more and more mobility. So we have more and more children who are bilingual and multilingual, or have at least bilingual exposure. And in fact, it is claimed that about 2/3 of the child population worldwide are multilingual. And with all this mobility that's going on, obviously, these children sometimes cannot avoid being multilingual. So obviously, clinicians are increasingly facing children who are multilingual, as well as their parents, and they obviously have possibly difficulties with developing language skills, either in both languages or in the language that they have been immersed in, if they have moved from one country, from the home country to another. And we're not sure whether these tests are also applicable to bilingual children. What we know is that bilinguals perform better than monolinguals on working memory. which is very interesting. We also know, it has been reported, that errors on sentence recall in bilingual children are different qualitatively from those occurring in monolingual children. Very often the bilingual children's errors are more related to word substitution, code switching, whereas children with developmental language disorder actually have fragmented sentences because of the nature of their condition. Next slide, please. Thank you. So, examining the association of sentence imitation and specific language domains in bilingual children should provide us with opportunities to support the theories of language development and specific cognitive processes. And this is very important since proficiency may be related to specific language pairs that a child is exposed to. It has already been, and it's increasingly being reported, that this varies from one language pair to another. And that brings us to our study and the aim of our study. Next slide, please. Thank you. Okay, so we wanted to identify associations between sentence imitation and speech and language skills in Maltese bilingual children. Now, by default, Maltese children are bilingual. We have two official languages, Maltese and English. Maltese is a Semitic language. It is the only language that is written in Roman letters, in only Semitic language, pardon me. It is written in Roman letters, and English is also an official language. So our children are brought up in a multilingual and bilingual context. And the objectives of this study, so it is a very good captive population to study such a hypothesis. So our objectives were to see correlations between sentence imitation and verbal comprehension, that is understanding of spoken language, narrative proficiency, how they are able to narrate, phonological awareness, this is a pre-literacy skill. So we wanted, which is obviously literacy is also a language component. We wanted to look into that. And we also tried to see whether there were correlations with two measures of speech production, and namely percentage consonant correct and inconsistency score. This leads to actually diagnosis of different types of speech sound disorder, some of which are language-based. Not all, though. We also wanted to identify whether sentence recall is a predictor of language domains. And if so, that would be very well taken in by clinicians because, as I have already mentioned, sentence recall is really a very short test to administer. It doesn't take long. Next slide, please. Thank you. Just giving you the map of the Maltese Islands. We are right in the middle of the Mediterranean Sea, between southern Italy, or rather Sicily, and North Africa. So we're really very much in the middle of the Mediterranean Sea. And we have a sister island, which is Gozo. We have a couple of other islands like Comino, but they're barely inhabited, although it is a very, for example, Comino is a very touristic place because of its well-known Blue Lagoon. Okay, so we started off with a random sample from the public registry of children between 2 and 6 years of age. We tabbed on 1,000 families. But even following reminders, the response was not as expected. It was relatively low. And besides, what you're seeing, 241 children were those children who managed to complete all the subtests. Obviously, we wanted to standardize these tests and check their reliability and validity. So we took all children into consideration, but some children, particularly those with severe developmental difficulties, didn't complete, and the younger group didn't complete all the tests, so we couldn't really analyze some of the data. Okay, we used speech and language subtests of a speech and language battery standardized on Maltese bilingual, Maltese English-speaking children. And data was collected in the child's home or in our university clinic, depending on the choice of the parents. Duration was depending on, you know, attention span of the children, and age was not more than 2 sessions and 60 minutes each to be able to administer all the tests. Next slide, please. Thank you. Just to give you an overview of the age cohorts and how we subdivided them in terms of boys and girls. There were fewer boys, but we weren't very worried. It was a random sample anyway, and the difference was, you know, around 11%. Between boys and girls. We had more girls than boys. I must say that the Maltese population is actually very small, less than 1 million. We wanted Maltese children, of course, who are exposed to Maltese and English, because nowadays 25% of our population includes non-Maltese residents. And that obviously restricted the sample size, but we're actually talking about, in terms of the Maltese population, around 400,000. And we normally have around 4,000 births annually. So the statistician informed us that our sample was statistically robust enough to proceed with the analysis and results. Next slide, please. Thank you. So we're going to talk a little bit about the results. We obviously wanted to see whether the sentence imitation task that we used was reliable enough, and we ran a test-retest on 10% of the children, and also an inter-rater reliability measure. And we found that these were the results using Cronbach's alpha and interclass correlations, were very good and clearly indicating that our sentence imitation task was a reliable one. And we also checked its validity. We did a run-through with various clinicians, particularly speech-language pathologists, for face validity as well. And we also ran some clinical analysis to see the robustness with a clinical population, which really identified the difference between the typically developing children and those who had a language difficulty. Next slide, please. Okay, I'm very aware of the time, so I'm just showing you tables here and results of correlations indicated clearly that the sentence imitation scores were correlated significantly with age and with some of the subtests. In some instances, they were more robust than others. Next slide, please, just to give you a better indication. Next slide, please. Right. We also ran regression analysis to see whether we could see whether the sentence recall test was a predictor of other language domains. As we said, this is easier to administer, quicker, and we wanted to see whether actually clinicians could administer this and get an indication of the child's understanding of language as well as the child's production. Next slides. I'll just give you a description of the results now. Okay, so basically, in a nutshell, the sentence imitation test or task was statistically found to be reliable and to be used as a screening measure as part of a language assessment battery. It correlated significantly with chronological age, which is what we were expecting, as that indicates that there is a developmental trajectory. As the children grew older, or rather were older, they had better scores in sentence recall. SIT correlations were also significant for phonological awareness, receptive language, understanding, comprehension, and narrative scores. And they were less significant for the inconsistency score and the percentage consonant correct, which are the speech tests. Next slide, please. Okay, so this test, sentence imitation task, is a strong predictor for verbal, it was the strongest predictor for verbal comprehension, less predictive for narrative skills, and it was also a predictor of phonological awareness. But let's concentrate on language here. It was identified as a good indicator of Maltese bilingual children's language skills and shows a significant relationship with performance on specific speech tasks as well as language tasks. It is not a predictor for inconsistency score and percentage consonants correct that the children produce, but this is what we were expecting, because these subtests are used to identify speech sound disorder rather than developmental language disorder. Next slide, please. So some clinical implications. Basically what the results indicate is that sentence recall as a screening measure has the potential to be clinically useful and facilitates valid clinical management decisions. So we could use it as a referral route for speech and language therapy, for example. The tests of verbal comprehension are time-consuming, as I already inferred, whereas sentence imitation takes a few minutes to administer. There are 10 sentences which the child is asked to repeat after the clinician or the administrator, and they are hierarchical as well. They increase in difficulty, both in the complexity of the sentences, grammatical complexity, as well as in the length of the sentence that they have to repeat. And this ties in with findings of other studies, which concluded that a sentence imitation task is clinically useful to measure language and working memory skills. So with this statement, I thank you and say grazie in Maltese. Although it's a Semitic language, we have a lot of influence. Maltese is a Semitic language from
I am introduce myself. I am Veronica Cornejo from Chile, and I work in the Genetic and Metabolic Disease Laboratory of the Institute of Nutrition and Food Technology at the University of Chile. I will present our research work analysis of the Chilean cohort with phenylketonuria with neonatal diagnosis, relationship between phenotype and genotype value, and IQ. I have no conflict of interest. Every year, around 120 million children are born in the world. If we consider a global incidence of 1 in 2,500 newborn, approximately 170,000 children will be born with an inborn error of metabolism each year. It is important to mention that only 28% of them are examined through a neonatal screening for one of these disease pathologies. Phenylketonuria PKU is an autosomal recessive defect. 95% correspond to a mutation in the enzyme phenylalanine hydroxylase, and the treatment is for life. The incidence for PKU in Chile is 1 in 18,000 newborn. The history of PKU in the world begins with Felin, who described PKU, then follows Wickel, who pointed out that the diet low in Phe was the treatment for PKU. But it was in 1963, when Dr. Gasri invented the technique to measure Phe in red blood, which made it possible to begin neonatal diagnosis of pathology and prevent the intellectual disability it caused. In Chile, the study for PKU began with Dr. Colombo. Then Dr. Raymond and I joined, who started the National Neonatal Diagnosis Program for PKU in 1992, which has allowed us to change the course of this disease in Chile. This is the metabolic pathway of phenylalanine, which when phenylalanine hydroxylase is inactivated, produce an increase of Phe levels and decrease of tyrosine level. Due to the inactive of phenylalanine hydroxylase enzyme, Phe accumulation occurs in blood, which will cause alteration in the central nervous system, causing intellectual disability if the disease is not diagnosed and treated early. In Chile, we have a national reference center for follow-up of patients with PKU. The clinical team is made up of doctors, nutritionists, neurologists, psychologists, and monitoring consists of determining Phe level frequently, adapting the requirement to the needs, and ensuring that they maintain good metabolic control throughout life. The treatment consists of the diet restricted in phenylalanine, Phe, which prohibits the consumption of food of animal origins because they are high in Phe. For this reason, they must receive a special formula without fee, which contain protein, vitamin, and mineral. In Chile, this formula is subsidized by the state. Frequently, monitoring is carried out, measuring the fee level depending on the patient age, weekly, bi-weekly, or monthly. Good metabolic control is considered when the fee value is between 2 to 6 milligrams per deciliter. In 2018, our work team publishes the characterization of genetic variant in 71 subjects belonging to the Chilean PKU cohort, identifying the most frequent variants. It was possible to predict phenotype by determining the phenotype, the genotype, and use this information to determine disease prognosis and adjust patient medical and nutritional management accordingly. The 84% of the subject had a classical phenotype. In 2020, we published an update of the cohort with PKU, analyzing metabolic, nutritional, and cognitive data of 271 subjects with PKU. As conclusion, for those under 18 years of age, 80% have a good dietary compliance with fee level between 2 to 6 milligrams per deciliter, and those over 18 years had a median of almost 10 milligrams per deciliter. The objective of this study was to analyze the relationship between metabolic control with the fee level concentration, cognitive development, and IQ, and the molecular study of Chilean PKU cohort. Regarding the methodology, a cross-section study was carried out on 127 PKU with neonatal diagnosis and who did not present any associated pathology in the period of 2019 and 2020. To determine the mental development index in the children under 4 years of age, the Bailey scale was used, and to determine IQ in older children, the Wesley scale was used. The molecular study was carried out by massive sequencing, was made in the University of Madrid, Spain, classifying the phenotype according to the allelic variant. As a result, we observed the age of diagnosis of the subject evaluated was 17 days of life with a fee concentration of 18 milligrams per deciliter. In the analysis carried out 2019 and 2020, the annual concentration of fee was 5.8 milligrams per deciliter. In that period, 22,000 samples were analyzed corresponding to the 127 subjects with an average of 16 samples for each one. In the relation of cognitive analysis, 90% of the children under 4 years old presented normal cognitive development with a mental development index score over 80. In individuals over 4 years old, 80% had a normal IQ. In the following graph, we can see the average score by age group, in which all are above the score cutoff of 80. Regarding the molecular study, 26 variants were detected. In this table, we presented the 5 most frequent. Then, when performing the classification according to the garbage, according to the allelic variant, 90% of the individuals which have a classical phenotype, and no association was observed between IQ score and relationship between genotype-phenotype value. When compared the group according to the Mental Development Index or IQ score, a significant difference in Phe concentration was observed, which means that the Phe level increased, there is a lower IQ. Here is when the IQ is over 80, the Phe level is lower than 6. In conclusion, the average Phe concentration is in 1 year is within the optimal range. More than 80% of PKU younger and older have a normal cognitive development. In relation to the molecular study, 90% of the variants represent a classical phenotype. The genetic variant does not determine cognitive development, but rather the Phe level during the follow-up. If it appears significant than when the Phe level is outside the recommended value, the IQ decreases. Neonatal diagnosis and continued monitoring by the multidisciplinary team are essential to prevent intellectual disability and promote adequate cognitive development. This is our clinical and laboratory team of University of Chile. Thank you very much.
It is my great honor and privilege to participate in this international webinar, which gives me the opportunity to present today the results of a prospective cross-sectional study, which was conducted from February 2019 to July 2022. The objective of this study was to investigate the association between cardiorespiratory fitness and insulin resistance in obese adolescents, including those with severe obesity. As you all know, obesity is defined as an abnormal or excessive fat accumulation caused by chronic imbalance between energy intake and energy expenditure. It increases the risk for many serious diseases and health conditions, including insulin resistance, prediabetes, and type 2 diabetes. Obesity is a growing global health issue, and many countries around the world have witnessed a dramatic increase in the prevalence of obesity over recent decades. This was observed in all age groups, including children and adolescents, both in girls and in boys. Unfortunately, such a trend is also present in many European countries, and Croatia is, as you can see here, one of them. Across Europe, 21 million children and adolescents are predicted to be affected by obesity, with 6 countries having over 1 million of children and adolescents by 2030. As you can see, Croatia is among highly positioned countries with respect to childhood obesity. Of particular concern is the fact that, according to available data from USA, the prevalence of severe class 3 obesity is increasing and has actually doubled in both girls and boys in less than 20 years. Obesity is closely related to insulin resistance. Insulin resistance can be broadly defined as a subnormal biological response to normal insulin concentrations. Moreover, insulin resistance refers to many biological actions of insulin in many tissues throughout the body. Typically, however, insulin resistance refers to resistance of certain tissues and organs, primarily the resistance of muscles, liver, and adipose tissue to insulin action.
I'm sorry for the interruption, but your slides are not moving.
Sorry?
Your slides are not moving. It's still in the first slide.
Can you please move it for me? Okay.
Okay, so we'll share
Is
the
it possible for you to move? Because I can see it moving. So can you please do it instead of me?
Okay, doctor. So we'll share it from our end. Okay.
Okay, please.
Okay.
I'm now on the 7th slide, I think. So if you can do it.
Yes, doctor.
Thank you. Okay, so the 7th, please. Yeah, thank you. I'm sorry. Okay, thank you. Thank you. So in the state of insulin resistance, a higher concentration of insulin is required to achieve the expected physiological effect. Inappropriate weight gain promotes the development of insulin resistance, which supports further weight gain and in some adolescents ultimately results in the development of prediabetes and type 2 diabetes. Next one, please. Can you move it further? Thank you. In addition to total amount of adipose tissue, its distribution is also very important. Central obesity with intra-abdominal visceral accumulation of adipose tissue is particularly associated with insulin resistance. It should be pointed out, however, that the amount of visceral adipose tissue can differ significantly among people of the same age, sex, body fat percent, and BMI or waist circumference. Please, next slide. Cardiorespiratory fitness refers to the capacity of cardiorespiratory system to supply oxygen to skeletal muscle mitochondria for energy production needed during physical activity. Cardiorespiratory fitness is influenced by biological factors such as genetic structure, age, and sex, and variable factors that can be changed like physical activities, dietary habits, and environmental conditions. Cardiorespiratory fitness and obesity are interrelated, with each being an independent predictor of cardiovascular risk. In adolescents, cardiorespiratory fitness influences cardiometabolic health, cognitive abilities, and academic achievements, as well as mental health. Research on the association between cardiorespiratory fitness and cardiometabolic risk in obese Caucasian adolescents is rare. Also, knowledge about the influence of cardiorespiratory fitness on insulin resistance and glucose metabolism in adolescents with severe obesity is incomplete. Therefore, the aim of our study was to investigate the association between cardiorespiratory fitness and insulin resistance in obese adolescents, with special emphasis on those with severe obesity, from whom the data about this topic are scarce. Next, please. Maximal oxygen consumption, or VO2 max, is the maximum rate of oxygen consumption attainable during physical exertion. It can be expressed either as an absolute value in liters of oxygen per minute or as a relative value in milliliters of oxygen per minute per kilogram of total or lean body mass. Next, please. And finally, there is no universally accepted definition of adolescence. Its key determinants are development, growing up, and transition from childhood to adulthood. Bad eating habits, lack of physical activity, and sedentary lifestyle in adolescents contribute to excessive weight gain, which promotes the development of insulin resistance. Due to hormonal changes during puberty, physiological insulin resistance develops and is further aggravated by the accumulation of fat tissue. Moreover, obese adolescents compared to equally obese adults have more pronounced insulin resistance, which can explain the earlier onset and more aggressive course of diabetes mellitus, the earlier onset of complications, and a weaker therapeutic response to drugs that increase insulin sensitivity. Next, please. The objectives of our study were to investigate the association between cardiorespiratory fitness and insulin resistance in obese adolescents, as well as in adolescents with different degrees of obesity. Please, next. The inclusion criteria were BMI higher or equal to 95th percentile for age and sex according to CDC BMI for age growth charts, age 10 to 18 years, and presence of puberty. The exclusion criteria were chronic diseases which prevent cardiorespiratory fitness assessment or affect either body mass or body composition, such as hypothyroidism, hypercortisolism, and syndromes associated with obesity. History of disorders of glucose metabolism disorder, and the use of drugs affecting glucose metabolism or body composition. Next, please. 200 adolescents who participated in this cross-sectional study were classified into groups according to obesity category and level of cardiorespiratory fitness. Obesity class 1 group included adolescents with BMI from 100 to 120% of the 95th percentile for age and sex. Class 2 group, those with BMI from 120 to 140% of the 95th percentile for age and sex, or with BMI greater than 35 kilograms per meter square, whichever was lower, while Class 3 group included adolescents with BMI greater than 140% of the 95th percentile for age and sex, or with BMI higher than 40 kilograms per meter square, whichever was lower. Adolescents in Class 1 group were considered obese, and those in Class 2 and 3 groups were considered severely obese. According to the terciles of cardiorespiratory fitness, participants were divided into groups with poor, intermediate, or good cardiorespiratory fitness. Next, please. During anthropometric measurements, adolescents were wearing minimal clothing and no shoes. Height was measured using a wall stadiometer, weight was determined using an electronic scale, BMI was calculated as weight divided by height squared, waist circumference was measured in standing position with a flexible non-elastic measuring tape midway between the most inferior rib and the top of the iliac crest. The pubertal stages were determined using Tanner's criteria based on breast size in girls and testicular volume in boys. Body composition was assessed by bioelectrical impedance analysis. The homeostatic model assessment of insulin resistance, or HOMA-IR, was calculated. OGTT was also performed. Cardiorespiratory fitness was assessed using a submaximal treadmill walking test according to a validated protocol for overweight and obese adolescents. Next, please. All statistical analyses were conducted using SPSS version 24. A one-way analysis of variance was used to test the influence of cardiorespiratory fitness on HOMA-IR, while the differences between the groups of obese and severely obese adolescents were analyzed using two-way ANOVA with Bonferroni correction. All analyses were adjusted for age, sex, and pubertal stage. P-values less than 0.05 were considered statistically significant. Next, please. And here are the results of the study. Next, please. The mean age of study participants were 14.5 years. There were more girls than boys. More than 72% of adolescents were in advanced puberty, and 64.5% were severely obese. Next, please. 21% of study participants had impaired glucose metabolism. There were 40 adolescents with prediabetes who had either impaired fasting glucose, impaired glucose tolerance, or both, and 2 female patients already had type 2 diabetes. Next, please. Groups of adolescents with different obesity classes differed according to majority of the measured variables. All three groups differed with respect to weight, waist circumference to height ratio, BMI, BMI Z-score, fat mass, and fat mass lean mass ratio in a way that all three parameters increased from class 1 to class 3 obesity group. Subjects with class 3 obesity had higher fasting insulin and HOMA-IR than subjects with class 1 and class 2 obesity, and VO2 max expressed in milliliters per milligram per kilogram of total body weight decreased from class 1 to class 3 obesity groups, while if VO2 max was expressed in milliliters per minute per kilogram of fat-free mass, the difference was significant only between class 1 and class 3 obesity group. Next, please. In obese adolescents, a weak negative Spearman's correlation between cardiorespiratory fitness and HOMA-IR was found. Next, please. Regarding the association between cardiorespiratory fitness and HOMA-IR in obese adolescents, next, please. A statistically significant main effect of cardiorespiratory fitness on HOMA-IR, can you put on, next, please? Okay. A statistically significant main effect of cardiorespiratory fitness of HOMA-IR was detected. Subsequent comparisons revealed that HOMA-IR was higher in a group of adolescents with poor than in groups of adolescents with intermediate or good cardiorespiratory fitness expressed in milliliters per milligram per kilogram of total body mass. Furthermore, HOMA-IR was higher in the group of adolescents with poor compared to group with good cardiorespiratory fitness expressed per lean body mass. Next, please. Regarding the association of cardiorespiratory fitness level and obesity class with HOMA-IR between obese class 1 and severely obese classes 2 and 3, can you put on? Next, please. It turned out that separate main effects of cardiorespiratory fitness level and obesity category on HOMA-IR were not statistically significant, but their interaction was. Obese adolescents had lower HOMA-IR than severely obese adolescents, regardless of their poor or good cardiorespiratory fitness. In severely obese adolescents, HOMA-IR was the highest in subjects with poor cardiorespiratory fitness. HOMA-IR of obese adolescents with poor cardiorespiratory fitness, however, did not differ significantly for HOMA-IR of severely obese adolescents with good cardiorespiratory fitness. Next, please. So the main finding of the study is that obese adolescents with good cardiorespiratory fitness are less insulin resistant than obese adolescents with poor cardiorespiratory fitness. Besides, HOMA-IR does not differ significantly between severely obese adolescents with good and obese adolescents with poor cardiorespiratory fitness. Next, please. This highlights the need to include the assessment of cardiorespiratory fitness in routine diagnostic algorithm and to encourage lifestyle-based strategies with special emphasis on cardiorespiratory fitness improvement in obese adolescents, including those with severe obesity. Next, please. Further research is needed to determine which interventions should be implemented in obese youth with low cardiorespiratory fitness in order to achieve optimal cardiometabolic effect, while at the same time making the prescribed activity feasible in real life. Current recommendations include combined aerobic and resistance training, as well as high-intensity interval training. Next, Phyllis. Finally, I greet you warmly from my university hospital center. Next, please. And my hometown, Zagreb. Next, please. Thank you for your attention.
To this international conference. Well, I'm very honored to be here. I am psychologist. I am researcher at CONICET, and also I'm a professor in Faculty of Psychology at Aconcagua University. The study I'm going to present today is titled The Impact of COVID Pandemic on the Development of Children Executive Functions, Implication for School-Based Interventions. Well, we know that the presence of chronic stress is one of the most powerful ways in which the consequence of the pandemic can affect children's development. Systematic review studies have reported that anxiety, depression, loneliness, and stress are the most commonly seen symptoms in children and adolescents. A decline in children's mental health, well-being, and quality of life have been documented. However, few studies have reported the pandemic impact on children's cognitive functions. That's why the goal of these studies are, first of all, to identify factors associated with the pandemic which may impact on children's performance and development of executive functions. And the other one is to propose a set of evidence-based strategies for teachers to assist children manage stress and promote executive function during crisis. Executive functions are a set of high-order cognitive abilities that controls behavior, emotions, and cognitions necessary to achieve goals, solve problems, and provide adaptive responses to novel or complex situations. 3 core executive functions have been identified: inhibitory control, working memory, and cognitive flexibility. These functions work in an interrelated way and enable the development of other more complex executive functions, such as planning, organization, metacognition. Executive functions play a critical role in cognitive, social, and emotional development of children and predict many life outcomes. Longitudinal study has documented that children who are better able to self-control their cognition, their emotions, are better able to adjust behavior to context demand, to establish positive relationship, to regulate emotion, tolerate frustration, have a good school performance, and those achievements predict better health, better quality of life, greater academic success, better employment status, and a lower incidence of conduct problems in adolescents and adults. Executive functions are considered critical for children's healthy development and pivotal resources for school performance. Executive function emerge in early childhood and present a lengthy development that continues into adulthood. Its lengthy development is associated with the late maturation of a set of neural networks coordinated by the prefrontal cortex. So, several sensitive periods have been identified. Executive function development is a result of the delicate and sustained interaction between brain maturation and the influence of the environment. That's why sensitive brain environment can strengthen executive function. However, a stressful environment can impair executive function development. We know that pandemic brings a lot of stressor to the life of persons. Families have experienced economic and social challenges, which have generated crisis and emotional stress in both adults and children. Some stressors were fear of illness, loss of family member, quarantine, loneliness, uncertainty about the level of the lockout, etc. We know that the stress can negatively affect physically and psychological health, well-being, and quality of life. In case of children, it has been documented that during pandemic and post-pandemic, children have suffered anxiety, stress, depression, who impair their integral development, and also can impair executive function performance and maybe slow their developmental trajectory. That's why I was very interested in analyze the pandemic pathway that may alter child executive function. I used a theoretical design to address the study problem and adopted the contextual ecological model of human development. I did a review and integration of 100 peer-reviewed academic publications, books, and web resources published between 2010 and 2023. Using all this information, I proposed this model, this ecological model, where we can analyze different factors that came from the child, family, school, or the macro system that can impair executive function performance, and maybe it can slow their development. I'm going to analyze the most important of this pathway. First of all, child stress. We know that child stress can impair immune and hormonal system, can cause neuroinflammation, and maybe alter or damage the central nervous system. And all these difficulties may affect the cognitive function of the children. In the case of executive functions, it has been established that child stress is associated with a decline in global executive functioning, a deterioration in emotional regulation, cognitive flexibility, attention performance, worsening in planning and organizational skills, and problems with self-control, discipline, hyperactivity in children. Another avenue that is very interesting is unhealthy habits. We know that during the pandemic, it has been an increase in the use of a screen, a reduction in outdoor activities, a reduction in physical activity, an increase in unhealthy eating habits that has been observed in children, which has been associated with weight gain, boredom, increased stress, and alteration in sleep. And this unhealthy habit impact in children's cognitive performance with greater problem in focusing and sustained attention, memory problems, and alteration in executive function. Another interesting avenue is family stress. We know that COVID brings stressor to family, health concern, financial difficulties, job loss, etc., that have increased parental stress. And the literature has documented that parental stress decreased involvement and the sensitivity to the need of the children. Parents are less predisposed to interact, to communicate, to stimulate children. Also, it has been documented that during pandemic, it has been an increase of the use of punitive parenting strategies, a greater frequency of family conflict and family violence. So all these situations really affect socio-emotional development of children and can impair cognitive functioning. Other avenue that is very interesting is the closures of a school. We know that prolonged school closure and remote learning has had a significant impact on children's school learning trajectories. Schooling is an experience that really foster the development of executive function. It has been documented that children who learn school context and skill more quickly are more willing to participate in increasingly demanding academic activities which stimulate executive function development. Another avenue is the changes in teacher-child interaction. We know that during pandemic, teaching instances have been reduced. Communication has been affected by internet problem, and learning mediation has become a challenge for teachers. Teachers has a critical role as a mediator of the cognitive development of children. Two ways have been identified by which teachers promote the development of children executive functions. One implicit, from modeling the use of executive function in daily school activities, and the other explicit, through scaffolding the development of executive function during classes. Another avenue that is very important is the limit to social interaction. Children have been the most affected by lockdown measures. Children develop in everyday interaction with important others. We know that in everyday interaction with peers, children put their executive function into play by regulating their emotion, practicing adaptive listening, solving interpersonal problems, and being flexible by taking the other point of view. So, limited to social interaction could impair executive function in children. So, in face of these difficulties, I designed a school-based intervention with strategies that are very easy to be imbibed into the school curricula, that teachers are responsible to deliver these strategies. And well, I'm going to describe now a pool of these interventions. First of all, I'm going to discuss teacher strategies to lowering children's stress. Some of them are, first of all, it's very important to identify children's symptoms of stress. So teacher should have a checklist of stress symptoms and use it to really understand the level of the stress of their students. And in this case, it's important to use the prior knowledge of the children to identify changes in their behavior associated with a stress trauma and identify child risk factor. Another important strategy is creating a structure and a predictable learning environment. Creating, for example, a way of do that, it's very important because we know that in crisis situation, we have uncertainty, unpredictability. So it's very important to create a structure and a predictable learning environment. And some strategies are creating a school routine, organize and plan their daily and weekly activity, create a sense of stability and foresight. For example, sharing a grateful moment at the beginning of the school day. Another strategy is to maintain a clear and a fluid communication. It's important to provide information as clear as possible, and teachers could use visual schematic, images, and reminder to facilitate the communication with their children. It's important to be flexible, to address academic and behavior issues with empathy and support. It's important to strengthen relationships, provide moments when children can enjoy the company of their peers, consider putting children together in a small group to work on projects or activities. Also, it's important to foster regulation of emotions. It's important to encourage children to express themselves, express their emotion by art, role-playing, and also teach children some technique to control their emotion. For example, deep breathing. Also, it's very important to communicate the school emergency response plan in case the situation changes. Also, it's very important to use mindfulness and relaxation techniques with children. For example, using a 3-minute mindfulness exercise at the beginning of the school day, or when children are tired or restless, help them to regain calm and improve their attention performance. And it's also very important to promote healthy habits, help children to identify and practice healthy habits. For example, it's important to include in the school activity a walk in the park, an outdoor activity, introducing the practice of mindfulness in contact with nature. On the other hand, I design teacher strategies to foster child executive functions. Some of them are, for example, for improving attention performance. It's very important to observe the children's attentional process to identify what captured their attention and what type of activities help them to stay focused longer. It's important to vary the stimuli and teaching methods, provide clear instruction, shortening the duration of activities, encouraging students to self-assessment of the attention. Improving inhibitory control, it's very important. We know that during crisis, the rules of the behavior change. So it's important to help children to internalize this new rule of behavior, for example, by placing poster in the wall, using visual signs, reminder. Also, it's very important to foster initiative in children. For example, playing again at the beginning of the class, do a stretching activity or a special welcome greeting. Also, it's important to carry out activities to reflect on behavior and emotion. For example, self-awareness, self-expression, self-control technique can be used. And relaxation techniques also can be used to improve inhibitory control. Working memory is a key executive function for learning. So it's very important to foster, and some strategies are starting a new topic, updating content learn, practicing mental calculation, using comprehensive reading techniques, proposing playful activities, for example, a cumulative song, or activities in which children must memorize multiple steps or action to reach a goal. Improving cognitive flexibility is very important. And a way to do that is modeling flexibility use in time of crisis by adapting tasks, activities, and evaluation to changing circumstances. Also, encouraging children to think of different approaches to problems, training them to perspective taking, using problem-solving techniques, brainstorm, and role play. Another important abilities are planning, and organization skill. So it's very important to create a monthly or a weekly school calendar that helps children visualize deadlines for homework and important school activities. Help them to use the school planner, checklist. Also, teacher can use roadmap to diagram for children the stages of the task to be carried out, making it easier to see the whole and its part. Also, it's very important to encourage children to carry out projects with the teacher able to scaffold the children planning a skill by, for example, identify goals, identifying the step to reach the goal, the resources, the time that is needed to reach the goal. And it's very, very important that when we are training children to manage stress and to improve executive function, to remind that it's very important to highlight the progress of children in the management of the stress technique and in the improvement of executive function. It's important to help children treasure their good deeds and achievement and to reinforce their value and their active role in the face of the crisis. So, in sum, the pandemic has had a significant impact on children's lives. The deterioration in the mental health, well-being, and quality of life of children have been widely documented. Children's ability to overcome challenges will depend on their internal resources and the support they obtain from their family and school. Teachers play a key role in identifying the symptom of stress in children, in helping them manage stress, gaining calm, promote resilience, and strengthen their executive function. So, it is necessary to train teachers in the application of evidence-based techniques and strategies. This challenge requires partnership between mental health professionals, school, family, and community. It requires listening to children's voices, stimulated their active participation, and empowering them as agents of change. I hope this study encourages practitioners to apply the recommended strategies to support children in crisis situations and examine their efficacy. Thank you for your kind attention.
Thank you, Dr. Korsteniowski, for your excellent presentation.
Neonatal Resuscitation Program of the American Heart Association and the American Academy of Pediatrics began in the USA in 1985 and in Mexico in 1995. The basic and advanced maneuvers of neonatal resuscitation are described in the textbook of Neonatal Resuscitation. This program has improved the outcomes and prognosis of neonates requiring advanced neonatal resuscitation, highlighting the importance of the golden minute of resuscitation. The textbook of neonatal resuscitation does not address issues such as A, the adequate or correct position in which gynecologists must pass and pediatricians receive the newborn. B, the adequate time to transfer it to the radiant warmer. C, the recommended or adequate time for each steps of basic neonatal resuscitation. If we do not control these issues, we prolong the initial stabilization period, giving rise to what we call lost time, which delays the start of advanced neonatal resuscitation by more than 60 seconds in non-vigorous newborns, depressed newborns. For vigorous newborns, it is recommended 1. Basic neonatal resuscitation on your mother's abdomen, favoring skin-to-skin contact. 3. Retarded umbilical cord clamping. For depressed term and preterm newborns who will receive positive pressure ventilation, there is not enough evidence to recommend 1. Retarded umbilical cord clamping. 2. Basic neonatal resuscitation on your mother's abdomen. According to the International Neonatal Resuscitation Guidelines, a severely depressed newborn can be ventilated, intubated, and undergoing chest compressions 90 seconds after birth. Our objectives were 1. Present and propose what we consider the correct position to pass and receive the newborn and each birth. 2. Expose lost time detected and how to eliminate them. 3. Establish the adequate time for each initial step of neonatal resuscitation. Material and methods: descriptive, observational, prospective, comparative, and triple-blind study. We analyzed 300 births, 150 cesarean sections, and 150 deliveries in 2 second-level hospitals from January to June 2017 in Cuernavaca, Morelos, Mexico. We recorded 1. The position in which the gynecologists pass and pediatricians receive the newborn. 2. The transfer time to the radiant warmer. 3. The time to perform basic neonatal resuscitation. We formed 2 groups. Group 1, professional who attends the birth and passes the newborn. Group 2, professional who receives the newborn and provides neonatal resuscitation. Gynecologist, pediatrician, general practitioner, nurse, etc. Triple blind. 1. Gynecologists and pediatricians blinded to the record of the position in which they pass and receive the newborn. 2. Pediatricians blinded to the recording of transfer time to the radiant warmer and to perform basic neonatal resuscitation. 3. Investigators blinded to risk factors at each birth. Inclusion criteria. Terms newborns greater than 37 weeks of gestational age. 2. Newborns without congenital malformations. 3. Mothers without diabetes, gestational hypertension, and 4. Births without risk of sepsis. We excluded neonates without this criteria. Results. The position in which gynecologists pass and pediatricians receive the newborn was not planned in 100% of both groups, and the time required was 5 to 10 seconds, 7.5 seconds. Positions found. Prone and transfer, 62%. Prone position with the newborn head towards the person passing it, 23%. Supine and transfer position, 10%. Supine position with the head towards the recipient, 5%. This last one is what we consider the adequate or correct position. Mouth and nose were suctioned 100% with a rubber ball in 5 to 10 seconds, average 7.5 seconds until the baby was completely born. Umbilical cord clamping was performed in 15 to 24 seconds, average 19.5 seconds. The pediatricians took 8 to 13 seconds to transfer and place the newborn under the radiant warmer, average 11.5 seconds. The distance traveled was 2 to 12 meters, average 7 meters. Until here, the sum of the times is 33 to 57 seconds, average 46 seconds. In the best of cases, 46 seconds to start basic neonatal resuscitation under the radiant warmer. Basic neonatal resuscitation was performed in 40 to 55 seconds, average 47.5 seconds. If we add the time to start the basic neonatal resuscitation, 33 to 57 seconds, average 46 seconds, the first neonatal evaluation was performed between 73 and 112 seconds, average 93.5 seconds in the best of cases. Therefore, the advanced neonatal resuscitation started after the golden minute. Lost times, lapses found, which can and should be removed. 1. Mouth and nose aspiration until the baby was completely delivered, average 7.5 seconds. 2. To pass the newborn in any position in 5 to 10 seconds caused the pediatricians to waste time turning, rotating, placing, and positioning to the newborn under the radiant warmer. 3. The textbook of neonatal resuscitation does not mention in how long and in what position to receive to the newborn. 4. We lose time when the radiant warmer is far from the delivery table. 5. We lose time when passing the newborn in any position. Passing him in the correct position eliminates at least 5 seconds of lost time. 6. The textbook of neonatal resuscitation does not recommend how to dry the newborn and in how long. We recommend drying it in cephalocaudal direction in 5 to 10 seconds. A, head and face. B, neck. C, chest, armpits and arms. D, abdomen, groin and thighs. E, legs and feet. This order is because it goes from areas of greater to lesser blood circulation, and therefore areas of greater to lesser loss of heat. Removing the wet blanket without technique generates lost time. The textbook of neonatal resuscitation does not say how or in how long. We recommend doing it in 5 seconds without lifting the newborn with the bedding change technique. A. Turn the newborn to one side and roll up half of a wet blanket as close to his back as possible. And at the same time, place roll up half of a clean, warm, and dry blanket on the same side. B. Turn to the newborn to his other side by passing him over the 2 rolled blankets in his back to remove the wet blanket and spread the clean, warm, and dry blanket on the other side. C. Return to the newborn to the supine position to continue with basic neonatal resuscitation. 8. Place the newborn in the sniffing position to open the airway and aspirate secretions, if necessary, with a rubber ball in more than 5 seconds. 9. Stimulate him if he does not ventilate by rubbing his back or the sole of one foot for more than 3 seconds. 10. Carry out the first neonatal evaluation and start advanced neonatal resuscitation, if necessary, after 60 seconds. Conclusion. In the course and in the textbook of neonatal resuscitation, they do not mention 1. The correct position in which gynecologists must pass and pediatricians receive the newborn in each birth. 2. Nor in how much time. 3. Nor the adequate time to transport it to the radiant warmer. Nor the adequate time for each initial step or the basic neonatal resuscitation. During the initial steps, it is where we detect most of lost time detected, lapses that we suggest eliminating to really perform basic neonatal resuscitation in 30 seconds, to perform the first evaluation and begin advanced neonatal resuscitation if necessary. It is desirable that a gynecologist attends the birth and passes the newborn, and a pediatrician or neonatologist receives the newborn, and between both to form a team informing the details of the labor or the indication of the cesarean section to anticipate the neonatal resuscitation process. In our environment, due to a lack of personnel, only one nurse simultaneously supports the gynecologist and the pediatrician. The latter often stay alone during the neonatal resuscitation. Nor do we have the personnel to control and notify the pediatrician of the time elapsed from birth to the first 30 seconds to perform the first evaluation. In the most recent literature consulted, only 2 actions are mentioned that reduce lost time to optimize the golden minute. 1, that the resuscitation cradle should be located next to the mother. 2, that the umbilical cord clamping should be immediate in the breast newborns, term and preterm. Aiming to eliminate lost time as much as possible, we suggest the above mentioned and develop a medical device called Neonatal Resuscitation Traffic Light Tutor. It's an application for smartphones and electronic tablets that controls the time second by second from birth and the time for each step of the basic neonatal resuscitation, so that whoever cares for the newborn does not depend on another person for this activity. Establishing respiration and oxygenation after birth is vital for long-term survival and health. Hence, inadequate initial cardiorespiratory support to the newborn can cause lung damage, lead to continuous hypoxia ischemia, and possibly brain injury. What we expose is based on the premise of the golden minute of resuscitation, because we are convinced that every second is vital for a depressed neonate. Perhaps these simple actions that we propose seem unimportant to many. In our experience, as neonatal resuscitation instructors since 1996, we have had good neonatal outcomes. Our results provide new concepts that could improve neonatal outcomes not only in our environment. However, further studies are required to validate them or to prove otherwise. In any case, the small details make the big differences. Conclusion: planning and accelerating the correct position to pass and receive the newborn in each birth, reducing the time of transfer to the radiant warmer, and shortening the time of the initial steps allow us to eliminate lost time, speed up and optimize the golden minute of resuscitation. Please look at this video. Carrying out this sequence of neonatal resuscitation steps that we recommend as soon as fast with a mannequin in neonatal resuscitation courses and in teaching hospitals in all newborns by delivery or by cesarean section will help reduce lost time and achieve enough training that in emergency cases, we complete them quickly and efficiently. In a maximum of 30 seconds, perform the first evaluation and start advanced neonatal resuscitation within 60 seconds. Thank you so much for your attention. It was my pleasure to have been staying with you. Until the next opportunity.
Thank you, Dr. Molina, for your presentation on neonatal resuscitation. It was an excellent work. Thank you for sharing your work, your knowledge,